Sir, good evening, sir.
Thambi Gopal,
Good evening, sir.
Gopal.
Sir, good evening.
Gopal Subramaniam, sir, good evening.
Sir, good
கோபால்
evening.
ஸ்டெத் என்ன வேற மாதிரியா இருக்கு.
Sir, good evening.
ஸ்டைலா இருக்கு.
கோபால் உங்க
Gopal.
ஸ்டெத் ரொம்ப வேற மாதிரியா இருக்கு, ரொம்ப அகலமா இருக்குது அந்த யூ ஷேப்.
ஏய் ஸ்டெத்தா
போட்டு அகலம் ஆயிடுச்சு.
Gopal, good evening.
Good evening, good evening, good evening.
Good evening, sir.
Good evening. I think you can start.
சார் குஞ்சு சார் குட் ஈவினிங்.
Good evening.
Good evening. Good evening.
Good evening, good evening.
We'll start it. Dr. Muhammad has joined. Yeah.
Dr. Kuju has joined, yeah.
Okay.
He has
Anna,
unmuted.
start பண்ணிடலாமா?
Yeah, start பண்ணலாம்.
Dr. Muhammad Kuju has joined. Only thing, ask him to unmute.
Srinivasan, sir, must be around 9:30 of morning.
Here, yeah. It is 10.
10 morning. Yes, sir. We can
Very
see
good
the sunlight, sir, in the back.
So shall we start the program, sir? It's already
Start.
Yeah, a very warm good evening to all the delegates who have joined on the platform and also to the esteemed guests who have joined, and a very warm welcome to all of you. We have starting another exciting session of postgraduate clinics conducted by IAP TNSE and coordinated by Dr. Kritika. We are very happy to have you all. So at the outset, let us have the pediatrician's prayer, and I request Dr. Rajkumar sir to do the honors.
Thank you. குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you so much, Dr. Rajkumar sir. Actually, even during the vacation time, there is a continued commitment from the team led by Kritika and Sringaravelu sir to conduct this program, just because our postgraduates are facing the exam much earlier. So this is the visionary leadership of Dr. Rajendran sir who made it possible. I request him to give the welcome address to the delegates.
Thank you, Dr. The most respected President 2024, Dr. Balashankar, and the President-elect Dr. Samasundram, and the Vice President Dr. Gopal Subramaniam, and Honorary Secretary Dr. Narmada, and Treasurer Dr. Rajkumar, and our academic coordinator Dr. Thirumurugan, and our scientific advisor Professor Dr. Sringaravelu sir, and our convener of the PG teaching program Dr. Kritika. On behalf of IAP TNSE, welcome one and all. So on behalf of IAP TNSE, welcome our today's faculty Dr. Srinivasan sir. Is none other than he's a teacher of teacher currently in USA. So he is actually eager to join here, and he is helping us for making our students preparing examination. On behalf of IAP TNSE, welcome Dr. Srinivasan sir. I welcome Dr. Muhammad Kuju sir. He is a renowned pediatric neurologist from Trivandrum. On behalf of IAP TNSE, welcome one and all for this event. And coming to that college presenting today is Coimbatore Medical College. Professor of Pediatrics, Dr. Sendil Kumar has joined, and learners Dr. Kalaivani, Dr. Madhimida. So on behalf of IAP TNSE, welcome. And I really appreciate Dr. Sasi Kumar. He's head of the Department of Pediatrics from Coimbatore Medical College. And I'm really thankful to him for making this possible. And this is actually, we are having past 6 years, we are doing a continuous teaching program, and we are having more than 2 postgraduate teaching programs in IAP TNSE website. I think we can ask our students to utilize this opportunity to prepare for the examination. And we are having coming the month end, we are having a Yuva Pedicon at Kanyakumari, and again our East Coast Pedicon also, followed by we are having August 14, 15, 16, 17 Kongu Pedicon at Coimbatore. So on behalf of IAP TNSC, I ask all the our students as well as delegates to make a registration and make it a grand success. Thank you, one and all.
Thank you, Rajendran sir. So it's such a pleasure that to host the postgraduate clinics of my alumnus. I'm a Coimbatore Medical College alumnus. It's such a great pleasure. And I have all the seniors, Dr. Sasikma, Dr. Rajendran from the same college. So with that, I will hand over the proceedings to Kritika, and a very warm welcome to Kalevani and Madhumita for the presentation. And all the best to you and Dr. Kunju sir. Since my time as a postgraduate, we have really enthralled by his lectures, and Srinivasan sir who was joined, and you both are very fortunate to present before such an elite persons. Now I give the platform to Dr. Kritika for further proceedings.
Thank you, ma'am.
Ask Dr. Singarwal sir, few words, Dr. Singarwal sir. Yeah.
Thank you, President sir. Thank you, Narmada. Respected President and all the dignitaries in the dais. And very happy that our postgraduate program is always going very useful, and a lot of people are joining in YouTube as well as in this platform. And today, my good friend Dr. Kunju sir is there, and with our learned professor Dr. Srinivasan sir, Dr. Senthil Kumar. I am sure that with Sasi's guidance, Coimbatore Medical College always will be pioneer in teaching program, because our president alumni of the college, definitely it will go very well. And Dr. Zareen also has joined well. And thank you to all the best, great learning. Thank you, Dr. Kunji sir, for accepting our invitation and be here. Thank you to all.
Thank you for the invitation.
Welcome, sir. Welcome.
Good evening, Dr.
Candidateship.
Kunju sir.
Yeah.
Good evening, sir.
Srinivasan, Dr.
Kritika, you can proceed.
Srinivasan, sir.
Okay.
You are always
Yeah,
there.
good evening, good evening.
Good evening.
Respected President
Kritika, you can
Rajendran sir.
proceed. Yeah.
Yes, ma'am. Yes, ma'am. Respected IAP TNSC President Dr. Rajendran sir, past President Dr. Balashankar sir, President-elect Dr. Somasundaram sir, dear Narmada ma'am, Rajkumar sir, Gopal sir, Thiru sir, and respected Professor sir, Professor Kunju sir, and Singaravelu sir, Sasi sir, Senthil sir, and dear students, a warm welcome. Today we are going to see the 5th session of Pediatric PG Masterclass, a case-based learning and scholarly lecture. We do have with us the learners from Coimbatore Medical College, Dr. N. Kalaivani and Dr. S. Madhumita, under the able mentorship of Professor Dr. M. Senthil Kumar, who is a professor of pediatrics in Coimbatore Medical College. And the today's faculties do not need any introduction across the country. Professor Dr. Srinivasan, though he is a professor, he wants himself to be called as a student. He is such an inspiring person. He wants to learn from everybody and every possible new updates. You are such an inspiration, sir. We are really thrilled and excited to have you and Professor Dr. Kunju, sir, who is an eminent neurologist and an extremely good clinician. And we are really excited to hear from you, sir. Dr. Kalaivani, you can please share the screen and start your presentation, ma'am.
Thank
Yes,
you.
ma'am.
Thank you.
Yes,
Thank
ma'am.
you.
Thank you, sir.
Thank you. So your comments need some correction. I will correct you later.
Okay, sir. Okay, sir.
Shall I start, ma'am?
Yes, ma'am. Yes, ma'am. Please, ma'am.
Full screen. Make it full screen.
Go to slideshow, ma'am.
Yeah,
Good.
fine.
Yes, ma'am. Yes, ma'am.
Good evening, ma'am, sir.
7 year. Male.
Master X, a 7-year-old male child, first born of non-consanguineous marriage from Udumalapet with the informant of mother and reliability of good, brought with the chief complaints of difficulty in using both lower limbs for the past 2 days. History of presenting illness. The child was apparently normal before 2 days. The child had difficulty in walking initially in morning and followed by not able to get up from squatting position in the toilet. And mother noticed buckling of knees. Child also had a difficulty in folding slippers. By evening, mother noticed the child found difficulty in turning side to side in the bed. On next day morning, the child was not able to get up from bed and had difficulty in lifting the hand above his head, and noticed difficulty in holding the glasses. On lifting the child, mother also noticed the flyness over the entire body. No history of fever, no history of breathlessness, no history of any altered sensorium, behavioral disturbance, sleep or speech disturbance, memory loss or seizures. No history of difficulty in appreciating smell, no history of blurring of vision, photophobia, or any other visual impairments. Child able to perceive colors normally. No history of drooping of eyelids, diplopia, deviation, or restriction of eye movements. He was able to perceive sensation over the face. No history of difficulty in chewing foods. History of difficulty in closing right eye, and there was deviation of angle of mouth to left side. And child able to hear normally, and no history of giddiness. No history of nasal twang or reduction in voice volume. No history of difficulty in swallowing, nasal regurgitation of speech. Child is able to turn the head side to side and able to proto-tongue normally. Child able to perceive pain and clot sensation and able to perceive hot and cold. No history of titubation or clumsiness. No history of involuntary movements. No history of palpitation, sweating or giddiness. No history of bowel or bladder disturbance. Mother also gives a history of child has a history of acute gastroenteritis in the form of fever, loose stools, and vomiting. 10 days back, she lasted for 3 days, treated locally, and child got better. No history of recent vaccination or exanthematous fever. No history of IM injections over the gluteal region. No history suggestive of any envenomation. No history of dog bite. No history of recent travel. No history of throat pain and swelling of neck. No history of intake of adulterated honey or canned foods. No history of recurrent joint pains, joint swelling or oral ulcers. No history of abdominal pain. No history of a dark color urine. No history of glossitis, hyperpigmented knuckles, or inhalation and ingestion of toxins.
Can I make a comment now? One comment?
Yes, sir. Please, sir.
Yes, sir.
Yes, sir.
Yeah. In your over enthusiasm, you have given so many negative points, keeping in mind your knowledge. Okay, but mother will not be knowing when the child is having such a severe problem. Mother will not be knowing so many things which you have written, no? Almost like various cranial nerve symptoms you have asked. So I think you must not bombard them with questions when they are having a problematic child with disability. How you are talking about sensation and so many other things. I think you should not be over exuberant. You must only ask what the mother says. You have shown your knowledge of taking history according to the neurology, cranial nerves, etc. You understand what I am saying? Dr. Kunju, you this thing you approve of my statement? Dr. Mohammed Kunju? She has written so many negative points, which will not be asking in a child who is having sick and mothers and they are all in distress. Okay, anxiety. You have written as if, when you are examining. Yeah.
Actually, this is only 2 days history. So if there is any problem in holding the pen, because that will help because you know about the digital
What they are telling you have to this thing mention first and then elaborate, and then subsequently you can mention some negative points. But not this thing. Yeah.
Okay.
That's it. Okay.
You agree with me, sir?
Yes.
And
Yes.
sir, why did you ask the history of the dark colored urine? Glossitis.
No.
Vitamin deficiencies or micronutrient deficiency, we also expect the weakness of the lower limbs, sir. So yes.
In this type of case, with the problem, what will you think of?
Sir, in vitamin B12 deficiency, there will be a subacute degeneration of spinal cord. In the lesion, it will also manifest as a...
What is the age of the child?
7 years.
So who will answer that? The acute intermittent porphyria is one condition which can present like a GBS. Okay. And they can have this sort of a urine changes. Okay.
Yeah, we had a case, 2 cases in Pondit Jipmer. Porphyria.
Continue.
And to rule out abdomen.
Yes, ma. Please be louder, ma.
And to rule out rhabdomyolysis, we asked a dark colored urine stream.
Okay.
And porphyria.
Yes, for porphyria.
No, every symptoms which you asked have relevance. I'm not criticizing that. But in a mother who is parents who are having so much of anxiety about the child having ascending paralysis, you will not be bombarding with them so many questions. You will be later examining and then getting these findings. That is my message. Okay.
Okay, sir.
Dr. Srinivasan, sir, I fully agree with him that only the relevant ones, which are the most common ones, comes to your mind by the everything, history and just these things. But not all, for all the differential diagnosis, not for all you should ask, na? You should mention. Only the very important which are relevant. Take those things, take those
Yeah,
things.
if you
That
happen to
gives
be in
more-
that position, you'll understand. The mother and the father will get more tensed up when you ask so many questions,
Yeah.
bombarding them. Yeah.
That is also.
Okay.
So proceed.
Past history. Child has no similar complaints in the past, no other comorbidities. Antenatal, later, and postnatal period were normal. Developmental history. Child is studying second standard. The scholastic performance is above average. Diet history. Child consumes mixed diet by 24-hour recall method. Diet contains adequate allowance of micronutrients. By 24-hour recall method, child has a deficit of 155 kilocalories with no protein deficit. Immunization history. Child was immunized up to age according to national immunization schedule. Received 2 doses of vaccine IPV and participated in pulse polio immunization. Last vaccine at 5 years of age. No recent vaccination.
What is the importance of immunization?
If child is not vaccinated against the polio and child is presented with
No, one immunization
paralysis.
one immunization vaccine can result in Guillain-Barré syndrome.
But why polio vaccine was given? Because lot of polio vaccine is being given. Why?
In that time, there will be a decrease in transmission of polio virus.
No, because oral and IPV, it is a part of our schedule. So it has to be given.
Yeah.
So one pediatrician cannot decide not to give it. Okay.
Only thing, influenza vaccine has been associated with Guillain-Barré syndrome.
Influenza vaccine, rabies vaccine, meningococcal vaccine.
So when you are mentioning such a this immunization, you have to specifically mention, because nowadays influenza vaccines are given. So you must understand that it may cause some cases of, good.
Can you tell me which vaccines are not covered in the national immunization schedule up to 1 year of age? Any vaccines you name? Which are not covered in the national immunization schedule, but the Indian Academy of Pediatrics says yes, they are to be given.
Typhoid vaccines, hepatitis A vaccine, influenza vaccine,
Influenza is one.
MMR,
And
MMR. In national immunization schedule, we are covering MR, but in IAP, MMR is covered.
Any other vaccine? The parents will say we can have any vaccine which is very costly also we can give to the child.
Influenza vaccine, meningococcal vaccines.
Any other typhoid vaccine at 6 months? Typhoid at 6 months is not included in the immunization schedule, and the meningococcal vaccine at 9 months of age also. No? That is very costly one. So you should know that these are not covered in national immunization schedule till date. They are not covered. But we recommend, Indian Academy of Pediatrics recommends them. Okay? Just.
Okay, sir.
You mentioned about the bowel. Have you mentioned about micturition? Whether there is any difficulty retention of urine?
No.
Because I don't know. I have been listening, but urine retention.
No bowel bladder disturbance.
That's a bladder you have mentioned.
Yes, sir.
Okay.
Yes, carry on. You're presenting very
Yeah.
well. Carry on.
Yes,
Carry
sir.
on.
Family history. No similar illness among family members. No history of acute gastroenteritis in family members. Socioeconomic history. Child lives in semi-paka house in urban area. The 4 rooms with separate kitchen and toilet. Total of 4 members in family. Child consumes clean boiled water for drinking purpose. No overcrowding. No history of breeding sites around the houses. According to modified Kupusam scale, child belongs to upper middle class and no history of similar complaints among nearby houses. Contact history. No history of contact with tuberculosis or COVID-19. Summary, a 7-year-old boy with a recent history of acute gastroenteritis 10 days back, followed by progressive symmetrical eccentric paralysis, along with difficulty in closing right eye and deviation of angle of mouth to left side. No history of suggestive of altered sensorium, sensory, autonomic, bowel, and bladder involvement. The diagnosis, the progressive ascending flaccid symmetrical paralysis with the right element type of facial nerve palsy, probably GBS.
You say full time, no, don't say GBS, Guillain-Barré
Okay,
syndrome.
sir.
No. Okay. So don't mention abbreviation while talking.
Okay, sir.
Yes.
Probably Guillain-Barré syndrome.
Okay, fine. Don't mistake me that I am pointing out some things. Okay. So you
No,
must
sir.
use
No,
the
sir.
full term and not yes.
You write this.
Dr. Mohammed Kunju, your please
Yes,
comments.
but why did you say that it's a GBS or a Guillain-Barré syndrome?
Sir, not
Well,
here.
what are the positive points and negative points? What are the other possibilities?
The child presented with the past history of acute gastroenteritis in the past 10 days back, and also there's a progressive symmetrical paralysis from ascending paralysis, and there is a no sensory involvement, no fever at the onset of paralysis, sir, and no bowel and bladder involvement.
So that is one point. That is a motor dominant, almost symmetrical weakness. Actually, to be starting as a proximal weakness because difficulty getting up from the sitting position, climbing stairs, or taking objects above the head like that. But that is why I told you because they may have initially the hand function better. Similarly, the foot function also may be better. But as it progresses very fast, both the areas will be involved. So most important point would be the predominant motor dominant symmetrical weakness. Okay, continue. And then what is the next point?
And there is also mother has a history of deviation of angle of mouth, and also no most commonly the patient is associated with Guillain-Barré syndrome. It is a
My question is deviation of face to one side. Will it be a diagnostic of GBS?
No, sir.
No, sir. Mostly in Guillain-Barré syndrome, there will be bilateral lower motor neuron palsy of facial nerve, but the mother given a history of angle of deviation of mouth, and but when we were examining, we found that the child had bilateral element facial palsy, sir.
Definitely, because see, all diseases, even though they are symmetrical, some amount of asymmetry may be seen. Okay. Then
There's no fever at the onset of paralysis, sir. And there is a
okay. And then anything else? Any because other things are any respiratory problem?
Sir, couldn't hear you, sir.
Respiratory, any issue of respiration?
No, sir. No, sir.
No. What about her voice volume?
Sir?
Voice volume of the voice.
There was no reduction in volume, sir. There was no reduction in volume.
Oh, initially actually it will be there, but once they develop this muscle paralysis, definitely there will be a decrease in voice. Okay. Anything else? Okay, these are some of the clinical points by which we will say that it is GBS. What are the immediate differential diagnosis with a similar history? Because this again is a pure motor paralysis. So what are the other conditions that will be presenting with a pure motor weakness? See, it is what is it? It is an AFP. So, so you'll be knowing all the readings. Only thing is that you have to say the differences very fast. That's all. Say. First is it could be poliomyelitis. Poliomyelitis or non-polio
first differential.
non-polio
Transverse
enteroviral infection. Okay, so what will be the points to say that it is not non-polio enterovirus but TBS?
Is under other enteroviruses which
Okay, I'll
cause
tell you. During the weakness, there will be high fever. Okay. Second, there can be asymmetry of the weakness. Asymmetry. Even the facial, if it is there, it may be asymmetrical. Because polio is a patchy illness, always, this non-polio enteroviruses, you remember the patchy illness. It is always a patchy illness. And as in this case, but there is no history of vaccination. Actually, vaccination may be in favor, but since other features are not there, we will not consider. Then what is the other motor? Two other motor, because you are
Transverse myelitis and
pardon?
And transverse myelitis child.
Very good, transverse myelitis. But what are the features of transverse myelitis to be differentiated from GBS?
In transverse myelitis, there will be a definite sensory level in, sir, and there will be an involvement of bowel and bladder involvement in transverse myelitis.
Okay. That is most important because transverse myelitis is a bladder.
There will be predominant bladder and bowel disturbances in transverse myelitis, sir, and it will be present throughout the course. In GBS, there may be a transient involvement of bladder and bowel disturbance. In transverse myelitis, there will be a sharp sensory level. But in GBS, there will be involvement of sensory system, but there will not be an.
Please stop. I'll just brief. So, any child who presents with bladder involvement in a child, usually it will be possibility of a spinal cord involvement. Second, there can be a spinal level. Okay. Third, when there is a level is there, below that layer there will be complete weakness. Okay. And in children, there should be sensory level sometimes because children may not tell the sensation or the change in sensations in a better manner. So what is the next disease which again has a pure motor weakness which will present in the acute manner? Anyone? I'll answer because I don't want to spend much time. That is the acute polymyositis. Either it may be a viral myositis in the acute phase or acute presentation of a PMDF, that is poliomyelitis dermatomyelitis. Because again, you know that polio, just like a GBS or a polio, it is again a pure motor disease. And in muscle diseases, where is the involvement? It is because if you take a DMD, what do? They have a go-go side, means they have difficulty getting up from sitting position. So usually, these children with the polymyositis will be having proximal muscle weakness. Second, the neck muscle weakness. Because in polymyositis again, neck muscle weakness. The other disorders also will have neck muscle weakness, but this weakness of the sternomastoid is a very important symptom. And if it is a DMPM, we will have a skin symptoms. Okay. So I'll just leave it. You must know the other differential diagnosis of the acute flaccid paralysis. I'm leaving it. Okay.
Sir, starting from the muscle level.
Okay. Continue. Continue,
From
Srinivasan.
Yeah. I think you can start. Go ahead. You can go ahead with your examination.
General examination. Child is conscious, orient to time, place,
Go
and
for
person.
the examination finding.
Hello, sir.
One thing,
Yeah,
of course, I
yes.
want to tell
Yes.
the history.
Hello,
Recently,
continue the
there have been-
examination finding.
So just 1 minute, sir, before
Yes,
that. In the history, I mentioned so many things, but
Hello?
recently there have been so many reports of newspaper reports in regional involvement of diarrheal disorders and this thing, and polio, this thing, Guillain-Barré
Oh.
syndrome-like syndrome. So you have to mention any
Yes,
episode in that area, because recently so many areas in India, states had increased incidence of
January
this thing.
2020.
Campylobacter outbreak.
Okay, proceed. Now examination.
Sound work. Okay, continue. Continue.
Yes. General examination. Child is conscious, oriented to time, place, and person. Respiratory rate, effort, and pattern normal. Child lying on the bed, the arms by the side, and both the limbs extended, rotated, and lateral aspect of feet touching the bed. No pallor, icterus, cyanosis, clubbing, pededema, or generalized lymphadenopathy. And head to
Just
foot
first the same slide. Please go back. So conscious, oriented, time, place, and person. You must say conscious, alert, active. Okay, of course, this child having motor problems, so may not be active, but the alertness is very important. Okay, that is attitude of the child, and alertness is very important. Time and place and all you will ask later only. Okay, but the child's appearance, not looking toxic or this thing ill. Okay, that will rule out acute infection. So that is very important to mention about the child's attitude, activity, and alertness. Okay. And of course, then you will talk about orientation, time, place, and this thing person. Because this child will be too early to talk about orientation to time and all. Okay, then. Yeah, proceed. Respiratory rate.
On head to foot examination, no glossitis, no oral ulcers, no patch over the tonsillar area, no bull neck, no malar rash, no fang marks, no cellulitis, no eschar, muscle tenderness, no neurokidneys markers or rash.
Vitals should come before this nose. Okay.
Even
so because hypertension can be there. Okay, in children with Guillain-Barré syndrome. So you have to mention no vitals before so many negative history. Okay.
even we can say no swelling on the neck also. That is bull neck is ruled out. Na? In that simple way also we can present sometimes. Otherwise, it means we are not knowing the diagnosis since beginning. Yes, this is. Then if the examiner asks you, then what is bull neck? It is there or not? Which condition it is there? Sir, I have already said there is no swelling in the neck. So that's why the bull neck is ruled out. Okay. Like that also you can do.
Guillain-Barré can cause hypertension, and also there can be evidence of this, respiratory muscle paralysis. So it's better to mention about vitals before you mention so many no's. Okay. Yes. Don't think I am too critical. We understand. So this is a very important thing, because acute Guillain-Barré can cause sudden death also. Yes. Yes.
This is just to make you even you're presenting very well, even your presentation more better, because in examination also we are preparing, like examiner can stop you in between and then ask you, na? So you should be in habit. This is just that, like that encouragement for you. Okay.
Okay, sir.
Very good. You have mentioned about no fang marks. Okay. We had a child with Lachlan syndrome in Mahatma Gandhi Medical College after my retirement from this thing. So child was later only we treated as Guillain-Barré, but later we found that there were 2 fang marks, and yeah, anti-snake venom also was given. So you mentioned specifically, very good. Yeah. Proceed.
On vitals, temperature of 98.6 degree Fahrenheit normal, respiratory 24, which is normal, the single breath count of 30 counts per breath, the pulse rate of 86 per minute, which is regular in rhythm, normal in volume and character, no radial, no radiofemoral delay, felt in all peripheral vessels. Rumor saturation of 99% with a blood pressure of 170 comes under normal centile, the adequate perfusion and warm peripheries, no diaphoresis. Anthropometry wise, child of weight of 20 kg comes under 25 to 50 centile, the length of 120 comes under 25 to 50 centile, and BMI of 30 and comes under normal centile.
At what age the child triples the height or the length at birth? At what age the child triples the height, or we can say the length at birth? What is the child triple? The length is 50 centimeter at birth normally. So at what age will he have the triple the height or the length at birth?
Multiple choice question.
6 years at double.
8 years,
1 year,
10 years,
the
12
child
years.
will have 75 centimeter, sir.
What is? This is a very common question. Asked in examination. It should be.
That's why I put it as a
6 years,
multiple
sir.
choice question.
Sir, in 1 year, the child will have a 75 centimeter, and in till
So
4
always
years, the child-
remember birth 50 centimeter.
centimeter. At 1 year,
Yes, at
75.
4 years it is about 100 centimeter.
100
And then
centimeter.
at 12 years it is 150, like that.
Yeah, that's why I told
The
you 12
formula.
centimeters, multiple choice
So you can
question.
answer easily, you can
Yeah.
answer that way also.
Okay.
You should in habit of having these questions also on your verbally, it should be presentable. Okay.
Dr. Vinay, actually 4 years it is only 105 because at
Yeah, and then
4
yeah,
years it
triples
is,
at 12 years. Yeah.
four times the birth length, that is 15 to 400, sorry, 100. And then every year age in the 6 plus 77 is the formula, but usually at 5 years it will be 5 centimeter. Sure, even though you have asked the birth weight, what will be the birth, the triples or doubles, or she did answer. So at birth, the birth by 1 year, it triples, isn't it? So sorry, it becomes 50 centimeter at birth, so it becomes 75. Okay, that way you must be able to say. Okay. Continue.
Systemic examination of central nervous system, higher mental functions, child is conscious, oriented to time, place, and person, able to interact normally, immediate, recent, and long-term memory good, intelligent and speech shows labial dysarthria, and child is a right-handedness. On cranial examination, olfact nerve, child is able to perceive smell of coffee powder in both nostrils separately. On optic nerve, pupillary reflex, there's a 3 millimeter, both eye 3 millimeter reacting to light. On distant vision, near vision, color vision normal. Field of vision, child could not be able to test it. And fundus normal and accommodation reflex normal. And third and fourth and sixth cranial nerve, child has no ptosis, extraocular movements full, no squint. And trigeminal nerve, child is able to perceive sensation over the face, and clenching of teeth, able to appreciate the prominence of masseter. No deviation of jaw on side-to-side movement, jaw jerk is elicible, corneal and conjunctival reflex not done. On facial nerve examination, there is a on wrinkling of forehead, there is a absent wrinkling on right side, so left side wrinkling is reduced. On tight closure of eyelids, child not able to close the eyelids. On attempting to close the eyelids, Bell's phenomenon noted. And not able to close the eyes tightly left side. On nasolabial fold, so completely obliterated in right side, so less obliterated in left side. On blowing of mouth, it's a weak on both sides. On deviation of angle of mouth to left side. And taste sensation of anterior two-third of tongue not done. And it's a bilateral lower motor type of facial palsy, right more than left.
So just I will tell you one formula we used to remember always in the patient paralysis. If it is, sir, if it is upper, if it is supranuclear, it is upper motor neuron type. And if it is infranuclear, it is the, we can say, lower motor neuron type.
Yes,
so in supranuclear, we will say S is sparing. So sparing of the eye means it is supranuclear. Eye is involved. So if the eyes are involved, that is in this case, then this is infranuclear. I infranuclear lower motor neuron, S supranuclear spared is the upper motor neuron type. Okay, so this is just to remember the formula also. You can just remember.
Vestibulocochlear nerve, On Reddy's test, air conduction is better than bone conduction. Weber's test, no lateralization, no nystagmus. On gloss of pharyngeal and vagus nerve examination, oolong in the midline, palatal arch equal on both sides. Child has no aphonia or dysphonia or coarseness of voice, no pooling of secretions, no nasal regurgitation, gag reflex present, and no nasal twang. On spinal axis nerve, child is able to shrug shoulder against resistance and able to turn it side to side. On hypoglossal nerve, child is able to protrude tongue, no deviation or wasting of tongue muscles, no fasciculations. Shall I proceed, sir? Motor system examination, bulk, no wasting and bilaterally symmetrical. Tone in upper limb and lower limb, there is a generalized hypotonia in all the four limbs. And power, there is a both neck and trunk muscles are weak. In power, the shoulder, elbow and radial ulnar joint and wrist joint, all are the 3/5 and hand grip are weak. And hip joint and knee joint, ankle joint, also 3/5 in all the four limbs. And reflexes, on examining superficial reflex, abdominal reflex present on both sides and cremastic reflex present on both sides.
Upper limb
And
have you
plantar,
told, ma? Power and upper limb have you told?
okay, yes, ma'am.
Yes, okay.
And bilateral plantar, no response. And deep tendon reflex and biceps and tricep supinator, it's a high diminished response. And knee and ankle reflex, no response on both sides. And sensory system examination, child able to appreciate.
When you
touch.
talk about power and this thing, you don't mention about joint. You mention about the type of this thing around the joint, which type, flexors, extensors, like that you have to mention.
Okay,
You
sir.
mention every time joint, So you mention specifically, see, you mention hip joint and all. So naturally, the movement will be around a joint only, but you have to mention, the anti-gravity or gravity muscles or specifically muscles. Okay, flexors, extensors. Okay, or supinators or pronators, like that. But
Okay, sir.
yes. Okay.
Sensory system, child is able to appreciate touch, pain, temperature, and push and vibration sense in both the limbs. No sharp sensory level and cortical sensations present. And cerebellar function test, no child has no nystagmus and no titubation. Other cerebellar function test not able to done due to weakness. And meningeal signs were negative and the spine and cranium normal, no spinal tenderness and no signs of autonomic instability. Other systemic examination.
Yes, just a minute. What are the various cortical sensations which you tested?
Tactile localization, 2-point discrimination, stereognosis, and graphesthesia.
Which is the easiest one? Easiest one.
Stereognosis.
Stereognosis. Very good. Very good. She has nicely elaborated all things. Good.
Thank you, Mr. Other systemic examination.
Can I ask a question, Kalaivani?
Ma'am.
Can I ask a question? You
Yes,
mentioned
ma'am.
that the neck muscles are weak.
Yes, ma'am.
You mentioned that biceps is present, slightly diminished on the left side, and triceps is present. Is it possible?
Yes, ma'am.
What is the root value of muscles in the neck and what is the root value of biceps?
The muscles in the root neck was C1, C2, C3, ma'am.
C3.
Mm-hmm.
And
biceps
C3
is
is affected and C5, C6 is not affected. C7 is not affected. Is it possible, Kalaivani? Madhu? Is it possible? And can I ask one more question? And you mentioned that the child is right-handed. How did you test it? What was the power in upper limb? What was the power in upper limb?
3/5.
Yes. How did you test it? You mentioned it in higher function examination, not in history. That's why I'm asking.
We asked her mother what.
That is in history.
Okay.
That is a history. Then you shouldn't tell it in the examination. Professor, am I right?
Yeah, naturally, when you say the power is so less, how can you this thing? Yeah.
When we asked the child to hold the pen, sir. He attempted to hold it in right hand first, but he cannot able to hold it properly.
Okay.
Hand
So
preference the right.
physical weakness was there.
Was that? Yes.
Okay. But you told that all the proximal distal muscles, everything was affected uniformly.
Yes, ma'am.
Okay. Okay. So that is my second question. And what is the importance of meningeal signs in acute flaccid paralysis?
In polio, we expect meningeal
Is
signs.
polio still in your country?
No, ma'am.
Yes, that is one thing which that is one thing, one new disease that is newly added in latest Nelson that mimics poliomyelitis. What is that?
West Nile fever. West Nile fever.
No. It is caused by enterovirus D68. Yes, what is it? What is the term? Actually, even in differential diagnosis, it is included in the tabular column in New Nelson. That is the first thing. Acute flaccid myelitis. So in that, they can have meningeal signs. It presents as meningitis with a prodrome of respiratory illness and then meningitis, and there may be involvement of respiratory muscle, and later on it goes on to present like poliomyelitis. That is pure motor illness with asymmetric weakness. Okay, that is the importance of.
Thank you for asking this question. Yeah.
Thank you, sir. Thank you. So that is the one thing. Sir, we have certain questions in the chat box. Can I ask it, sir?
Yeah, why not? I didn't see the chat box, yeah.
Dr. Kumar M has asked, you have mentioned fang marks, but not asked about history of snake bite. And he asked whether you have asked honey ingestion. Yes, you have asked adulterated honey. Excessive sweet intake, he had asked, what is the importance of it, Kalaivani? Does it precipitate anything? No, sweet intake. That is carbohydrates, excessive carbohydrates.
Periodic paralysis.
Yes. Did you ask for it? Did you ask for those precipitating factors? So better include it.
Okay, ma'am.
No. But here, of course, this is the first episode. So periodic, this thing we not immediately think of.
Yes, sir.
Unless there is 2 episodes, then yeah. That's why probably they. Anyhow, this point is valid if there are more than 1 episode. Yes.
Okay. So do you have any other questions, sir? Shall we proceed?
Too much of information may kill the information. Yeah, that's why I said you must be very careful, when you're talking about an acute sick child. You must not unnecessarily, bombard with questions the parents, because you must understand their psychology and other things. This is very important human this thing. So in your enthusiasm in presenting, you're asking so many questions, which will further cause more anxiety in the parents. You understand what I'm saying?
The mother is in Viva and exam.
Yeah, of course.
But,
very relevant questions.
Yes, sir, please.
You must say some investigation and treatment points. That did not say. I think I didn't hear.
Yes, sir.
To say
Yes.
any investigation and treatment points.
Yes, sir. Actually. So after concluding your history, you have to tell about the treatment details I is telling.
Yes, ma'am.
What about the treatment? What was the complication? Was there any progression of illness? What was any event in ICU?
Okay,
and what was the intervention done? That is a treatment history you have to tell.
Okay, ma'am.
Proceed.
Yeah, it's very important.
Go
Now
back.
you can tell
Go back.
this particular history I have taken, whether any intravenous medications were given or any this thing, child was admitted in intensive care unit.
Yes, sir.
These are all important. Then you know what is this thing. Okay, usually a very important point. Yeah. So what is whether the child is referred to some other center?
No, sir.
No, it's important. Type of hospital where the child has been taken care of, whether it's primary, secondary, or tertiary care, this thing.
No, sir.
Or referred from, yeah.
Child was admitted initially on high dependence unit, and we monitor for the progression of weak and diagnose acute flaccid paralysis, and monitoring for the progression of weakness for the first 2 days, sir.
Okay.
And Since for the initial 2 days, child has no progression of weakness, and after 2 days, in view of rapid progression of weakness, and we started an IVIG immunotherapy, 400 milligram per kg for 5 days, sir. And child gradually improved after 3 days, and weakness and power reflex are improved, and facial
Probably you
palsy
didn't
improved.
mention these things earlier because it gives immediate diagnosis. Probably you withheld that, but it's very important in a presentation, especially in a long case, to mention what has happened to the child, whether the child has moved from the general ward to this intensive care unit, and what you can send. You did not mention intravenous immunoglobulin unless the mother says, okay, in the history. But you can see some intravenous medications are given by this thing, and child has shown improvement. That you can mention. Yeah, good. Thank you, Kritika, for bringing out these valid
It
points.
actually narrows so many negative histories. This particular
Yeah, that's
treatment
what.
history
So
will
many
narrow down so
unnecessary
many
negative
negative
histories there, but this
history.
is more important.
Yeah, because you will be given only 30 minutes in your final exam.
Okay.
Thank you,
And
ma'am.
even the examination, the whole examination you have to finish in 40 minutes. Long
Sir,
case.
only 30 minutes, sir,
Yeah.
for them.
Okay.
They have 3
Yeah.
cases, one neurology case and one newborn
Okay.
case, and each 30 minutes, and then one other system case.
Okay, fine.
Okay. Yes, ma'am.
Proceed.
Other systemic examination, cardiovascular system, precardium is quiet, no bradycardia or tachycardia, and rhythm was regular. And respiratory system examination, the respiratory rate, effort, and pattern was normal, no paradoxical breathing, no added sounds, and single breath count was 30 counts per breath. And the abdomen examination, abdomen is soft, no organomegaly, and bowel sounds were present, and bladder not distended. Summary, a 7-year-old boy with a recent history of acute gastroenteritis 10 days back, followed by progressive ascending symmetric paralysis, and an examination, hypotonia and hyporeflexia in all 4 limbs with bilateral lower motor type of facial palsy, right more than left, with no signs of meningeal irritation, no evidence of sensory, bulbar, and autonomic dysfunction, probably acute flaccid paralysis with Guillain-Barré syndrome. Diagnosis.
Professor Kunju, sir, any questions?
So that's why this history, what Kritika mentioned is very important. That child has been given IV immunoglobulin, it has been showing improvement, and the child has become better. That will give a definitive diagnosis. Okay. So, yes.
Professor Kunju, sir, any questions?
Yeah, Dr. Mohammed Kunju.
Actually, she has presented. Again, I have given the DDs. So, does she remember the DDs I have mentioned?
Yes, sir. Starting from muscle.
Pardon?
Starting from periphery, I will. If it is muscle pathology, if the child have proximal weakness more than the reflex and more than the distal, and that is the reflex are preserved in the prox. And examples like hypokalemic periodic paralysis and rhabdomyolysis and.
So I mentioned which disease? I
Sir?
mentioned which disease?
Transverse myelitis.
Transverse myelitis.
No, the muscle disease.
Myositis, viral myositis.
No, polymyositis. Acute polymyositis.
Acute polymyositis.
Okay. What was the second DD?
There is a neuromuscular junction. There is a easy fatigability, and the child has a.
Okay, I didn't say, but okay, you have to consider that. Okay, then. Okay, then. Okay.
If it is a neuromuscular junction, the paralysis will be relapsing and remitting, and the easy fatigable weakness. There is a more of a descending type of paralysis.
Good. Okay, then.
And it's a peripheral now. There is a distal is more involved than proximal, and glove and stalk pattern of weak.
Excellent. Okay, excellent.
And sensory involvement present. And if it is a nerve root, the pain is radical pattern of pain is present, and symmetrical ascending paralysis. And if it is anti.
Any other DD I mentioned?
Anterior horns, there may be asymmetrical involvement and asymmetrical patchy paralysis
So,
also.
so what was the disease I mentioned?
Poliomyelitis or
Any other than
enterovirus.
polio?
Non-polio virus, enterovirus.
No, non-polio enteroviral infections. Okay.
Okay.
Which is anyway, I'm not going to that. Many non-polio enterovirus are there. Okay, so you all read about it. Okay. Okay, continue. Don't just fix your all postgraduate. So when you're reading and presenting, once you present, you must add knowledge to your existing knowledge. That is very, very important.
Okay.
Continue.
Diagnosis: a case of acute flaccid paralysis, probably Guillain-Barré syndrome, with a bilateral lower motor type of facial palsy, with no bulbar or autonomic dysfunction, with a normal development and nutrition status, and child is immunized up to age.
What is the present condition of the child? Has the child improved?
Yes, ma'am.
You
Improved.
didn't tell about that to us. You didn't tell about that to us.
Improved in what all aspects? Power, tone, or this thing. Okay. So mention exact areas in which a child has shown improvement. If you examine the child again, before and after. Otherwise, you may not be able to tell. Yes.
Sir, Kunju sir, I just wanted one query. The child is immunized up to the age. Is it we are considering only the vaccinations as by the government, advocated by the government, or we consider with the IAP also, sir? Which
Actually, because nowadays our all children, we must give adequate protections because the vaccines are not that costly. So better to go for the IAP schedule. But since our national schedule, they will give it free. So for example, MMR, we all give only MR,
Yes, sir.
So we give MR also. So polio is there. Polio, both IPV and OPV will be given in the schedule. So it is there.
Yes, sir.
And don't forget about diphtheria. So DPT is usually given, but even at 10 years and 15 years, this DPT has to be repeated. That is the best thing. Okay.
In this case, what are the investigations which have made the diagnosis conclusive?
We should have done a nerve conduction study.
Those things are important.
Shall I say just briefly so that I think always students get confused? Because in GBS, first and foremost, we may do the LP. But many times I don't go for LP because there is no need. But looking for albuminocytological dissociation. Second, being a neurological disorder, you will do NCV because this nerve conduction velocity. So velocity means in GBS, it is demyelination. So the fastness of the conduction may be determined by the myelination. So when the demyelination is gone, the NCV may become low because usually it will be 50 to 70, but in this case, it may be less than 40. And the initial phase, because there is again demyelination, the demyelination will show when you are doing the NCV, no doubt. A distal latency, because we will do the NCV by stimulating the distal part of the nerve. So usually the distal latency may be prolonged. Third, all of you know about two things. That is one, F response. Because again, F response, why affected? Because in GBS, it is as we said, a radiculopathy. Because the proximal radicals are affected. So the proximal part of the nerve may have demyelination. So when you stimulate the nerve in the distal part, the electrical impulses will go to the anterior horn cell and come back. So that is what is called as F response. So usually it will be depending upon the length of the child and the length of the arm. So we'll say that there will be reduction of latency. Usually it will be less than 10 or 15 because it is a gross disease. H reflex also will be affected. And two more points usually we say they are the compound the muscle action potentials because the multiple nerves are stimulated now. So there can be a temporal dispersal. Just learn it because there can be a temporal dispersion of the action potential, and there is a because in between some area there is a demyelination. So there is a conduction block will be there. Okay, so these are some of the investigations. So I'll just stop it because if I say more, you may confuse. So these are the investigation results. Okay, good. Okay, continue. Okay.
Yeah, proceed.
Proceed, ma. The investigations.
We proceed to the investigations. We do a basic investigations first of complete blood count. So say hemoglobin of 12 and the RBC of 4.9 is normal. Hematocrit of 12 and platelet of 4,48,000. And the sodium of 138.
Normal you can skip. Normal you can skip.
And then we done a nerve conduction study on 1 week, which shows a bilateral upper and lower motor type of motor and sensory axonal neuropathy. An MRI brain with the spine gadolinium contrast shows a normal, and CSF analysis at the end of second week after shows a macroscopically it's sterile, which is a clear. The CSF cell count of no cells, the protein of 110 milligram per deciliter, the CSF glucose of 82 milligram per deciliter against 118. Proteins were elevated.
Nerve conduction study told you that it is AMSAN, is it not? AMSAN. It is AMSAN. But here the child has recovered so well with your IVIG. Usually they say it is an AMSAN, they have a poor prognosis. But here the child has recovered very well, right?
Yes, ma'am.
But was any sensory disturbances in your child clinically?
No, ma'am.
No. Okay. Next, ma'am. So normally what do we expect an MRI brain? When did you do the MRI spine? At what stage of the illness? First week, second week, third week, like that?
Second week.
Ideally, when should it be done?
Ideally,
What do you
MRI
expect an MRI spine in case of GBS?
MRI spine is not needed for the diagnosis of Guillain-Barré syndrome.
Because even NCS is not needed for the diagnosis to differentiate or classify. So there are so many criteria, right? Modified Ashbury.
Yes, ma'am.
And another criteria?
Modified essential criteria like progressive weakness of.
What are the criteria you know?
Modified Ashbury criteria.
Another one is Brighton's criteria. So in Brighton's criteria, if there is an evidence in case of NCS, it adds up to the diagnosis. It elevates the level. That's all.
Okay,
but MRI spine should be done either on the second day so that you can see the cauda equina nerve root enhancement.
Yeah, that is very important. Yeah.
With contrast.
Okay.
So it is not to be done on the second week. It is to be done on the second day. Because all the other tests, like your, as you told, NCS and CSF analysis should be done at the end of the first week. Whereas you can get the clue from the MRI spine, where there can be cauda equina nerve root enhancement. And cell count, how many cells you can allow?
Less than 10 cells.
Actually, it is given 50, I think. You can allow up to 50. Okay, ma'am.
Proceed.
Course in the hospital, as if child is diagnosed a case of acute flaccid paralysis, Guillain-Barré syndrome. Child initially admitted in the high dependence unit and monitored daily for the progression of weakness and bulbar autonomic dysfunction. And we took acute flaccid paralysis report to surveillance health inspector, and 2 stool samples were sent at interval of 24 hours.
How did you assess for autonomic dysfunction?
Yes,
I mean, you are looking for it, right?
Yes, ma'am.
What were all the warning signs you are looking for?
excessive sweating, lacrimation, and postural hypotension.
Good.
And
Postural hypertension and postural variation of the heart rate, that has to be done. Good.
We also daily examine for the single breath count and any use of axillary muscles and any paradoxical
I
breathing.
had a doubt in that also. You told in the examination single breath count was 30. Was it before treatment and after treatment?
Before treatment.
Before treatment, ma'am.
But neck muscles were weak. That is contradictory. Quite contradictory. Okay. Proceed, ma. Proceed.
We daily assess the child for a single breath count and use of axillary muscles and signs of respiratory failure, and also autonomic and bowel bladder dysfunction. And the initial 2 days, child has no progression of weakness and no bulbar autonomic dysfunction. On third day, due to progression of weakness, child is attended immunotherapy 1 gram per kg for 2 days. After 2 days of IV immunoglobulin, weakness gradually improved in the form of child able to get from bed and able to sit without support. On bedside examination, there was return of refluxes on third after 3 days of immunoglobulin. Child able to walk independently on day of admission 9. No bulbar or autonomic dysfunction throughout the hospital stay.
I just wanted to know whether you have been regularly examining the child during this thing, or somebody, this is from the notes.
Sir, we examine the.
So
daily you went and examined. Okay.
Yes, sir.
Because you're
how
presenting
did
a case,
the
as
weakness
per
manifest?
examination. So I was wondering whether you have taken from the case record that improvement, etc. Okay, yes.
How did the weakness progressed on third day, ma'am?
Initially, child was up to upper
No, what
limb.
was the progression? That's all. What was the progression?
Child had we found that the person single breath count was decreased in he was not able to do the single breath count what he done on the routine monitoring. So we assess that is a sign of declining. And
okay, ma'am. How long will you wait for it? Watch for progression. And how long GBs can progress?
Up to 4 weeks.
To
maximum 4 weeks.
4 weeks.
4 weeks.
Very good. But this is relatively a very rapid recovery.
Yeah. That's good for the child and the family, yes.
Child was discharged in day of admission 15, and knee and ankle reflex were present, and bilateral facial nerve palsy improved. Lumbar function was done, shows albinocytological dissociation, and bacterial cultures were sterile, adding to the diagnosis. Time of discharge, child able to walk independently, but able to raise hand above the head and no facial limb asymmetry. Power of upper limb and lower limb at time of discharge was 4/5, and there is a mild difficulty in closing the eyes. Difficult in tight closure of eyelids.
Good.
Yeah. Dr. Kunju, please. You want to ask any more questions or comments? Dr. Mohammed Kunju, you are there?
Mohammed sir? Mohammed sir?
We'll wind up here. If some more questions, I think others can ask and you can answer. It was a very nice presentation. So, very good.
Thank you, sir.
Professor sir, any comments and questions?
No. Yes, of course. Only thing I have mentioned a few things, that too much enthusiasm should not be there in asking too many questions to anxious parents. Okay, especially when the child is having this thing. So don't go on asking about so many negative things. Okay, so that is the only point I wanted to make. Okay, so in our enthusiasm in presenting a case, so we must not try to get so many informations. Sometimes, it will be very. It's a parent, sometimes they may take the patient to some other hospitals. Okay. Anyhow, it's good that they have mentioned, and thanks, Kritika, about mentioning that management, whether in the general ward or whether the child has been taken to intensive care unit and what has been given. then it would have given a very good this thing. Thank you so much.
Thank you, Professor
Yeah.
sir. Thank you, Professor Kunju sir.
There are so many theoretical
Sandil-
things that can be asked. Some recent this thing
Yes, sir.
advances in journal is there.
Yes,
Okay, so you can read that Nature 2025. There is one article on Guillain-Barré syndrome. You can.
Okay,
It's
sir.
very informative. Yes.
Okay, sir. Okay.
She presented
you.
very well, sir. Very well presented and very
Yeah.
well compiled also.
Yes,
It
sir.
was to the
Absolutely.
point.
Absolutely.
Congratulations.
Sandil sir, any comments? Sandil sir,
Yes, ma'am.
that was really a wonderful presentation, an efficient presentation from your PG sir. Comments, please, sir.
Okay, thank you, ma'am. Sure, ma'am. Okay, just I want to register my few comments here.
Yes, sir,
One
please.
thing's regarding the immunization. Okay, she told about rabies. The rabies vaccine producing post-demyelination is almost, it's become the, this vaccine is not being used now. We are using only Virocell vaccine. So the chance of having post-vaccination demyelination is quite unlikely. So I think the rabies, as such, I now we are having more of the dog-bite menace, where the rabies can present as dumb rabies, mimicking GBS, in which case that is most important rather than the rabies vaccine causing post-demyelination and GBS. And second thing regarding influenza vaccine, the postgraduate should not go with the idea that influenza can cause post-vaccination demyelination. Yes, it is true, but the chance of having post-vaccination demyelination is hardly 1 to 2 per 1 million doses of influenza vaccine. But the disease is going to cause much morbidity and mortality. With the influenza illness. So you should not never have any hesitancy in giving influenza vaccine to the pediatric kids. And second thing, regarding the BP, what you have mentioned is 100 by 70 mm of Hg or something like that. See, if a child is above 13 years, yes, a single value, that is, this value is highly taken as appreciated. But any child who is less than 13 years, the definition always depends upon 3 parameters. One is age, one is 6, other is 5. So always mention, whenever a BP is mentioned, for the age, sex, and height of the child, and you tell the percentile. And you also tell whether it is normotensive, hypotensive, or pre-hypertension. Now the terminology has been changed. It is elevated BP, or it is in stage 1 or stage 2 hypertension, especially in a case like this where there is autonomic disturbance is expected. And regarding management, okay, you mentioned about IVIG, always mention in 2 parts, supportive therapy and specific therapy. The supportive therapy is the most important. Even if you are not giving IVIG, the child may recover from GBS, but without supportive therapy, I don't know whether the child will recover or not. Always give importance to supportive therapy first, and then you can mention about the specific therapy. And I also, my final question for you. You are telling about IVIG. Hope the plasmapheresis is another modality of treatment, but since IVIG is being easily available and it is, for pediatric population, we are preferring IVIG. Suppose we are giving IVIG, 2 kids, one is one child GBS, we are giving IVIG, one child with GBS, we are doing plasmapheresis. What advice you will give regarding live vaccination for a kid who have received IVIG and for a kid who has received plasmapheresis?
Both are equally effective.
What's your recommendation regarding live vaccine, say for example MMR and varicella? And what's your recommendation for a child who has received plasmapheresis?
For 8 months, we should wait for IVIG.
Actually, it is 11 months for the dose which you are using for Kawasaki, and there should be a minimum gap of 11 months is needed. For plasmapheresis?
For plasmapheresis, no need.
No, again, it has minimum of 6 to 7 months you have to deny. Okay, because again, in both the situations, definitely the antibodies this is going to interfere with the vaccines what you are giving. Okay, so you have to that protocol for each and everything for IVIG, for transfusion related, especially fresh blood, FFP, and all those things. That guidelines has to be followed. Okay, that's all, ma'am. Okay.
Excellent point, sir.
Thank you.
Excellent
Thank
points.
you.
Thank you so
These
much.
points very important that you have mentioned.
Excellent
Thank you
points.
so much.
Thank you, sir. Thank you.
Senthil sir, one point I wanted to ask. Besides influenza vaccine, which other vaccines we should ask in detail about the history, na?
So, actually, almost even influenza vaccine and the meningococcal vaccines are the two, the two important vaccines which can cause, though it is, sir, but the chance of having those post-vaccine demyelination is hardly less than 1 to 2 per 1 million doses, sir. But the morbidity and mortality is definitely going to be high when it caused due to illness. Just why I mentioned this postgraduate.
No, very important point. Yeah, we are not this thing. You understood why you have mentioned it. So we should not unnecessarily cause
yes, sir, panic
problem. Yeah. So we must not over exaggerate the importance of the vaccine when compared to the regular infections.
Yes, sir.
Thank you.
Thank you. And about the anti-rabic vaccines, sir, anti-rabic vaccines.
Anti-rabies vaccine also in our country, actually in still few countries they are using the neuro tissue vaccines, sir. But now almost we are using only virocell vaccines. So the chance of having rabies following virocell vaccine is definitely, it's unlikely. But definitely I am much worried about the, actually we have to give importance to the, because of the dog bite menace, definitely the incidence of rabies has come up. So even 20% of rabies can manifest as dumb rabies, that is mimicking GBS with the encephalitis. So such a scenario, how to diagnose rabies ante-mortemly? Okay, those things I think more important rather than rabies vaccine causing GBS.
Recently, one Chinese study had dismissed all these vaccines as a etiology for GBS, influenza, rabies, and everything. Sir, we have some questions in the chat box. They have asked about nerve conduction that you have answered already. Any role of plasmapheresis they have asked already, you have answered.
Yeah, already, and most of them have been answered.
Yes,
yeah.
sir. Any role
I
of
saw the
steroid?
questions. Yeah, most of them have been addressed. Probably they came late or they were not attentive.
Oral steroids we can prescribe for radicular pain and also gabapentin. What about botulism? They had asked about adulterated honey, sir. Also in this age, we cannot talk about. And also it will be a descending paralysis, botulism, and more of bulbar weakness. And pupillary response will not be well, and all those things. And here cranial nerves were normal except the 7th cranial nerve.
Thank you, Kritika. I learned a lot from you today.
Thank you so much, sir. We have a very short presentation.
It was a great discussion, sir. Great discussion. Thank you, sir.
Thank you so much.
And thank you, Senthil Kumar, sir. And Nandish, sir. Your comments, sir. Nandish, sir, is also, sir.
Sasi, sir.
Yeah. It's unfortunate I am not there to attend Pogu Pedican. So, and I'll be missing that. But any hope you will be able to send me some of the PowerPoint presentations.
We have a very short presentation on GBS, sir. So, Professor, if you can go and take care of your relatives, sir. Thank you so much for being with us, sir.
No. If it is going to be shown now.
Yes, sir. Only 10 or 15 minutes. I'm going to.
Yeah, I don't mind. I'm having time because the guests haven't come yet.
Sasi, sir, any
guests
comments?
are expected. Yeah, I'm there.
Yeah, thank you, Kritika. That was an excellent.
Thank you so much, Sasi, sir. It was an excellent presentation from your PGs.
Yeah, thank you very
much. Your valuable inputs and Dr. Senthil Kumar's inputs are very good. Yeah, thank you.
Kaliman, you can start sharing the screen, ma.
Comments for Nandish,
Thank you,
sir.
ma'am. Thank you, ma'am.
Thank you so much, Kaliman.
Thank you, ma'am.
It was an excellent
Nandish.
Yeah,
Nandish,
sir.
sir.
It was a
So
wonderful
nice to
case
see you.
discussion, sir. Thank you very much for such a
Sir,
wonderful
can I share my
session.
screen, sir?
Thanks to all.
Yeah, please. Kritika, you are presenting.
Yes, sir. Yes, sir.
Okay.
Sir, is my screen visible, sir?
Make it full screen. It is in the slide mode.
Yes, sir. I couldn't actually.
மேல இருக்கும் 3 dots. You have to. Above, this thing, there will be 3 dots. You have to click on that, and that.
Yeah, I will see, sir.
It's all right. It's visible. You can mention. You can continue like this.
I have some actually animation, sir. So I think Yes,
Then
yes, sir.
it's better. Yeah, it has come. Yeah.
Thank you so much for the opportunity, sir, for this.
No. We are learning. So kindly go ahead.
So actually, what is expected from a postgraduate in university exam? We are expecting so much from postgraduates, both in university exam and also in emergency room. Here, we are not going to talk about the expectations in emergency room. We are going to talk about the expectations only in the university exam. So general points. Actually, sit straight with grace and greet the examiners politely and present confidently, meeting the eyes of the examiner. So practice presenting without looking at your notes to your friends. So it adds more value if you present without seeing your papers. And you use the
I one
CNS
point
kit.
in this I want to make,
Please, sir.
Not only eyes of the local examiners, because local examiners will give some hint. So
okay.
you must constantly look at all the examiners. Otherwise, some examiners get annoyed. I have experienced it, not as a student, but as a co-examiner. So they get annoyed. Why you are looking only in one distinct direction? You are not looking at us. Okay,
Yes,
that
sir.
is important.
Sure, sir.
Okay.
Point well taken, sir. And use
Yeah.
the CNS kit effortlessly when you are asked to demonstrate any clinical signs. Don't look at the CNS kit and fumble with it as if you are looking at it the first time. When you're asked a question, don't rush. Observe the question for a few seconds, then answer. If you can't remember the answer, please take 2 deep breaths and try to recall. And regarding AFP, so first, in history taking, we are expecting you to localize the lesion and also tell the probable etiology. And in vital signs examination, we expect you to tell about autonomic disturbances. In neurological examination, precise localization and most probable diagnosis is expected from you. And at every level, whether it is a history taking or vital signs, or whether after completing an examination, you discuss the differential diagnosis. And you are expected to know in toto about AFP surveillance and polio, both vaccines and also about the disease. And then discuss about the investigations and treatment options. So localization. Suppose what is localization? If I want to enjoy my break if I want to go for a vacation, I need to consider so many different points. Whether I want to go abroad. If I do not have a visa, I cannot go abroad. I can spend my vacation only in India. In India, where do I want to spend? That depends upon the number of holidays I do have, whether I'm having 1 month or 1 week. So if it is only 5 days to 1 week, I prefer to stay in Tamil Nadu to avoid travel. In Tamil Nadu, if I want to avoid any air transport, only by road transport, I prefer only within the reach of my place, that is among the hill stations. So this is summer, so I prefer a hill station. So in hill stations, what is the most nearer to me? So I choose Kodaikanal. In Kodaikanal, I want to spend whether in a resort or sightseeing. That depends upon choosing the place where I want to stay. This is localization. So this depends upon my need. And also I need to do some various research, both in the net or if I go there and see when there is something is not there in a resort I expect, I can change it. So this is the same with the examination in a case of CNS also. So the first thing, whenever a child presents with pain or a weakness, it could be either in the musculoskeletal system or it may be in the nervous system. In the nervous system, it may be either in the central nervous system or the peripheral nervous system. In central nervous system, it may be either in the brain or the spinal cord. In peripheral nervous system, it may be in the anterior horn cell, or it may be in the radicle, or it may be in the nerve, or in the neuromuscular junction, or in the muscles. So in history and examination, we are going to look for the clues to localize. So pain and weakness. In topographical evolution, so if it is both pain and weakness, even GBS can have pain earlier, but the topographical evolution of ascending paralysis and symmetric paralysis gives you a clue. And then positive or negative sensory symptoms like numbness or paresthesia again give you a clue that it is a nervous system. And if there is any presence of altered behavior or sensorium or seizures, then we can localize it in the brain. When there is a bladder and bowel involvement earlier, it can be in the spinal cord. If there is an asymmetry and pure motor, it may be mostly in the case of the anterior horn cell. When there is a diurnal variation, increasing fatigability and more preponderance for facial muscles, it can be in the neuromuscular junction. And in examination, if there is any sensory level or a palpable bladder, it can again be a spinal cord lesion. And topography, if it is an asymmetrical illness, then most probably it can be an anterior horn cell or a traumatic neuritis. If there is any cranial nerve involvement, it tells about the severity of weakness and also group of the muscles, particular predilection for muscles. For example, if it is a facial muscle, ptosis, any bulbar, then it can be a neuromuscular junction disorder. And areflexia is the most important clue in the examination to localize, because areflexia, it rules out neuromuscular junction and also the muscle disease and localizes it to the nerves or the radicals. So the prototype disorders. So in a case of musculoskeletal system, polymyositis or dermatomyositis, and encephalitis in CNS, and acute transverse myelitis in a case of spinal cord, and anterior hornsel, the prototype disorder is polio, and neuromuscular junction, the prototype disorders are myasthenia or botulism, and radiculopathy, it is GBS, or traumatic neuritis, a single nerve. And as I told you, acute flaccid myelitis is a new disease that can be localized either into the anterior hornsel or into the cranial nerve nuclei in case of brainstem. So in history, the presenting illness should be with a good structure. Elaborate the illness, progression, topography, evolution, and also chronologically how it progressed. And assessing the severity should be your next point. Whether there is any respiratory system involvement or bulbar dysfunction, any cranial nerve involvement, and severity of weakness is assessed by both the respiratory involvement or the neck muscle weakness. And ruling out the other differential diagnosis. For that, we can ask the history of fever as in a case of poliomyelitis, early bladder bowel involvement as in a case of your spinal cord, sensory features and sensory level again in the case of spinal cord level, and neck muscle weakness, both to assess the severity. And also neck muscle weakness can be there in case of hypokalemic periodic paralysis. There may be early involvement of the neck muscles. And also polio, there may be involvement of the neck muscles. Myalgia can be there in a case of GBS, or if it is severe, it can be a polymyositis. Abdominal pain as in case of acute intermittent porphyria. Look for clues towards the probable etiology. Any prodromal illness for GBS, any precipitating factors for hypokalemic periodic paralysis, or any bite or sting history, any travel history, whether they have attained any tick bite, sore throat or neck swelling for diphtheria, rash in case of connective tissue disorder, intramuscular injection in case of traumatic neuritis. And always tell about the treatment given and also the response to it. Specific drugs and respiratory support should be mentioned. And complications, whether the child had any pressure source or any nutrient deficiencies. And finally, past history, any similar illness, any family history, any significance, and immunization history is must. An examination, distribution of the weakness, they have mentioned it very clearly. And I really appreciate how they mentioned about the power, best possible power in each joint with particular importance or emphasis to shoulder abduction, because difficulty or inability to abduct the shoulder, it tells you that the child may need intubation in the near future. And cranial nerve examination, particular emphasis on seventh nerve, extraocular movements, pupillary responses, and also the lower cranial nerves. Deep tendon reflexes are very, very crucial in localization. Sensory system examination, examine all sensory modalities and also the sensory level. Meningeal signs as in case of acute flaccid myelitis. Gait disturbances in the case of mild variant of GBS. Other systems, CVS, postural variation in the pulse and the BP should be mentioned. And as Sendil sir had mentioned, always mention it with a percentile. And respiratory assessment, single breath count, I really appreciate them. They had done that. And palpable bladder and abdomen should be told, and they have told it. So this is the example history, the same here. So from history, no CNS involvement, then the lesion is at the spinal cord or PNS involvement. No bladder or bowel involvement, probably not spinal cord level. Ascending paralysis of all four limbs, rules of diphtheria and botulism. Symmetricity, rules out poliomyelitis. Sensory motor, again rules out poliomyelitis. Assessment of the severity. Like this, you have to present. Like this, you have to substantiate. So here there is no CNS involvement. The paralysis is ascending, no bladder or bowel involvement. It should be in an order, and you have to rule out one by one. From history, so I am localizing it to nerve or the radical. That should be your answer. So same as in the case of examination also. Distribution of weakness is like this. So the best possible power in each joint. I am appreciating weakness in all the four limbs. And cranial nerve examination, the seventh nerve is involved. And deep tendon reflexes are absent. And sensory system examination is normal. And there are no meningeal signs. So with all these positive findings in history and examination, I am localizing it to the peripheral nerve or the radical, like Guillain-Barré syndrome. So this should be your summary. Summary of the history, summary of the examination, including positive and relevant negatives, and final diagnosis. So like investigation to confirm the diagnosis, MRI, spine with contrast, nerve conduction studies, CSF analysis, antibodies, this we have discussed. To rule out the next possible differential diagnosis in case of inconclusiveness, like MRI, spine and brain, potassium, CPK, parfobilinogen, toxicology, and repetitive nerve stimulation test. And this NCS is mainly useful for classification of illness, whether it is a demyelinating or a AMAN or AMASL. So these are the two criteria that are used in case of Guillain-Barré syndrome. And management, as Sir told, ABC stabilization and anticipation of complications like autonomic disturbances should be mentioned. Intravenous immunoglobulin, plasmapheresis or other immunosuppressants, and supportive treatment should have a special mention in the form of ventilatory support, nutrition, physiotherapy, and preventive measures also. So AFP surveillance, you should never forget how we have to collect the sample and how we have to send. And efficiency of the program is assessed by collection done for more than 80% of the cases of AFP, and also non-AFP cases reporting in 1 in 1 million. So that tells about the efficiency of the program. And also know all the important milestones. Last case, declared polio-free. When was the polio switch done? Future goals and target timelines. For time being, I'm skipping all the dates. Future goals and target timelines like novel OPV and what is enhanced IPV, and in detail about the OPV, and also about the vaccine-associated paralytic polio and vaccine-derived poliovirus. So all these things are expected to be known to you. And thank you so much, sir.
Madam, one comment.
Sir, please.
Especially in this summer, because they are talking about influenza vaccine. And influenza illness in summer because of dehydration, they present with rhabdomyolysis, presenting with acute flaccid weakness. Even we treated this at GBS, and the final diagnosis was rhabdomyolysis. Child improved and went home. So keep that also is in possibility.
So we have to look for muscle tenderness, and also CPK should be done in the investigations along with potassium. So potassium, CPK, and muscle tenderness in examination will give clues to us in ruling out rhabdomyolysis. Point well taken, sir. So if there are no comments, shall I please end the discussion?
That's a wonderful coordination. You contributed so many things, Kritika. Thank you very much.
Thank you so much, sir.
Everything was self-explanatory. Yes.
So my
heartfelt
very well compiled. Very well.
She has written a wonderful book. This thing, I don't know whether you have seen Kritika's book.
Sir.
Yeah, she's a real this thing. I just now typed something. I want to be your student again.
Sir. Oh, sir. What are you, sir?
Congratulations.
Thank you so much.
Thank
sir.
you, Senthil Kumar. Your students presented very well. And thank you for your comments also. We also learned a lot. Thank you.
Srinivasan sir.
Thank you, Srinivasan sir.
Today was
Yes.
a great academic feast. No, Saturday feast, great academic feast today evening. Yes.
For all of us, sir. For all of us.
Yes.
So my heartfelt thanks to Professor Dr. Mohammad Kunji sir and Professor Dr. Srinivasan sir for accepting our invite and teaching so many things to us. And my heartfelt thanks to Dr. Rajendran sir, Narmada ma'am, Rajkumar sir, and past and present and future dignitaries of IAP TNSC. And my heartfelt thanks to Sasi sir, Sedil sir, Kalaivani, and Madhumita for presenting in such a wonderful and comprehensive manner. And special thanks to Devendra sir for all your contributions. And my sincere thanks to Singaravelu sir for the opportunity, and Thiru sir for coordinating the meeting and for guiding me in every stage. And have I left anyone? Thank you one and all. Thank you, students.
We like to thank our HOD and professors and assistant professor for guiding us through the journey.
Please go ahead.
Good.
Thank you.
Thank you. Good night.
Thank you. Nandip sir, thank you.
Thank you, sir. Thank you, sir.
Thank
Good
you
night,
for
sir.
Nandip sir. Okay,
Good night,
Srinivasan
thank you.
sir.
Good night, all, sir.
Okay,
Good night,
Sasi
sir.
sir.
Good night.
Okay.
Good night,
Good night,
all of
good
you.
night.
Thank you, sir. Thank you.
Okay.
Thank you so much, sir.